Bismillah ar-Rahman ar-Rahim. Today we are going to speak about the prostatic cancer and the last lecture in the urinary system. The incidence carcinoma of the prostate is a common malignant lesion that affects male usually over the age of the 65. Predisposing factor, family history, the relative risk is greatly increased if one or more of the first degree relative have the disease. Race, there is striking difference in the racial distribution of the prostatic cancer. African and American have the highest incidence, and Native Asian population have the lowest incidence. Age, they show in the autopsy studies the prevalence of the prostatic cancer show a constant rise over the successive decades starting at the age of the 50 years. Pathology, gross picture, the majority of the neoplasm, about 75%, arise from the peripheral zones beneath the capsule. The tumor appears as a hard infiltrating bare nodule. Microscopic picture, 95% of prostatic cancer are adenocarcinoma derived from the acinar epithelium. There is grading system of the prostatic cancer, which is called the Gleason's grade, based on the degree of the glandular differentiation and growth pattern. Grade 2 is the latest malignant, while the grade 10 is the most malignant. The spread of the malignant prostatic cancer, either direct invasion to the neighboring structure, the involving the seminal vesicles, pre-prostatic tissue, and rarely the rectum. Why? Because the fascia of the denuvaliers acts as the barrier. Ureteric obstruction occurs in 20% of the case of prostatic cancer. Lymphatic spreads is to the internal, external, and common iliac lymph nodes, then to the para-aortic lymph nodes. The obturator lymph nodes may be also involved. Blood spread, 90% of the blood bone metastasis occurs in the bone, especially the lower vertebrae, neck of the femur, pelvic bones, and the ribs. The preference of the pelvic and lumbar vertebrae for metastasis is attributed to the reversal of the blood flow from the vesico-prostatic plexus to the imaginary veins of the pelvic bones during the coughing or sneezing. Metastases are usually osteoplastic. Rarely metastases develop in the lung or in the liver. Clinical picture. The symptoms of the prostatic cancer are symptoms of the urinary outflow obstruction. The majority of the patient complain from difficult micturition, acute retention, incontinence, hematuria, or painful micturition. A short history of these symptoms in male above 65 years is suggestive. Pathological surprise, the diagnosis may be reached only after routine histopathological examination of the prostate that was removed with a preoperative diagnosis of benign prostatic hyperplasia. Metastasis, the first presentation may be due to metastasis, backache, sciatica, edema of the lower limb, spontaneous fracture, or paraplegia may occur. And routine screening with the prostatic specific antigen that show the high level, suspicious, and warrants further investigation for confirmation of the diagnosis. Examination. Digital rectal examination reveal a hard, irregular induration in part or whole of the gland. The median sulcus is obliterated. العكس في حالة ال BPH. It is to be noted that the normal digital rectal examination does not exclude the diagnosis. Staging system depends on the TNM classification, what you call it T tumor size, N lymph nodes, and M metastasis. T0 no clinical abnormality, T1 nodule in one loop, T2 diffuse disease, T3 extension to the seminal vesicles, T4 lesion is fixed to the other tissue. N level, N0 no evidence of involvement of the one regional nodes, N1 involvement of one regional nodes, N2 involvement of several regional nodes, N3 fixed mass of regional nodes, N4 involvement of common iliac or para-aortic nodes. M, we have M0 and M1. M0, no evidence of the distant metastasis, whereas the M1, distant metastasis. Investigation. We have laboratory investigation, including the prostatic specific antigen, PSA, is the most useful marker to diagnose and follow up. The normal value ranging between 0 to 4 nanogram per milli, a rise level suggests prostatic cancer. Marked elevated of prostatic specific antigen more than 20 nanogram per milli suggests of disseminated disease. The serum level is not affected by rectal examination, but it may be mildly raised in non-malignant condition as in prostatitis, benign prostatic hyperplasia. Acid phosphate is raised in 70% of the patient with extracapsular or metastasis disease. Acid phosphatase is raised in many other conditions as Gaucher disease, Back's disease, and of the bones and breast and gastric cancer. Alkaline phosphatase is raised if there is bony or hepatic metastasis. Blood picture and blood urea and creatinine to exclude the renal impairment. Imaging, we have plain X-ray of the chest, pelvis, spine to detect metastases, which are usually osteoblastic. Bone scan by technetium 99M will detect area of increased bone activity. CT scan of the pelvis can help to detect the pelvic lymph nodes deposits, but it's also not accurate. Transrectal ultrasonography, TURS, can give an accurate idea about the extent of the lesion and they give about the staging of the prostatic cancer. Biopsy, any patient with the abnormal rectal examination and or elevated prostatic specific antigen must undergo multiple transrectal biopsies under ultrasound guidelines, TURS. Treatment. There are many policies in the management of the prostatic cancer. Treatment will be directed by the local extent of the disease, the presence of the metastasis, and the general condition of the patient. The first modality is the radical prostatectomy. This is the only performed for early localized disease in the fit patient. It entails removal of the prostate and seminal vesicles together with the block dissection of the obturator and internal and external iliac lymph nodes. The bladder is then anastomosed to the urethra. The complications include the urinary incontinence in 5% of the patient and incompetence in 30% of the case. The second choice is the irradiation. This is the indicated if for locally advanced disease and unfit patient. External beam radiation therapy is applied giving a dose of 7,000 Gay over a 5-week. Radiation therapy has some side effects like bladder irritation and produce diarrhea or bleeding per rectum. Irradiation has also got a useful role for symptomatic bone metastasis as it produces dramatic relief of pain. The third choice is the transurethral resection, TURB. Those who have bladder outflow obstruction and or not fit for major surgery can have satisfactory symptomatic relief after TURB. The fourth option of treatment is the hormonal therapy. This is the mainstay for treatment of advanced case or in patients who are unwilling or unfit for surgery or radiotherapy. The rationale for hormonal treatment is that prostatic cancer is androgen sensitive tumor. There are different methods for androgen ablation. The first is bilateral orchidectomy or orchectomy. Orchidectomy means excision of the testis with the tunica albuginea and together with the epididymis. Orchectomy means removal only the testis tissue from inside and tunica albuginea is in order to avoid the appearance of the empty scrotum. Both operations are effective, easy, and safe. Their advantage are loss of libido and the disadvantage are loss of libido and erectile dysfunction. The other option is the luteinizing hormone releasing hormone LHRH agonist like Zaldex. The drug cause initial rise of level of the testosterone for 4 to 6 weeks, then a drop to castrate level. It gives equal result to castration and has some side effect, and it is expensive drug. The other is the anti-androgens. Natilamide. This acts by blockage of the testosterone receptors by competitive inhibition. They are used as adjuvant to castration or luteinizing hormone releasing hormone antagonist. The third by estrogen, and estrogen acts as anti-androgen. A small dose of the stibulysterol, 1 milligram TDS, it is used. Its major disadvantage is that to predisposing to deep venous thrombosis. Ethinyl estradiol may be also used. The last choice is no treatment. Small, well-differentiated tumor in elderly men may be managed by the watchful waiting, particularly if there is anticipated life expectancy is less than 10 years. Prognosis. The life expectancy of the patient with the incidental finding of focal carcinoma of the prostate is that of the normal population. With tumor localized to the prostate, the 10-year survival rate is 50%. If metastasized, the 10-year survival rate drops to the 10%. This is the diagram, shows the treatment of the prostatic cancer in early and late stage. In early, can do radical prostatectomy, radiation, watchful waiting. In late, just URB or hormonal treatment. We spoke about the prostatic cancer, and the next lecture about the torsion of the spermatic cord, torsion of the testis. Testicular torsion is a surgical emergency. It means torsion of the testis and epididymis around the axis of the spermatic cord. معناته التواء التستس والابيديديمس. Etiology. This is an uncommon problem occurring usually in adolescents, and predisposing factors include imperfect descent of the testis, like incomplete or ectopic descended testis, long mesothelium, and copious tunica vaginalis that surrounds the whole testis. The testis is suspended loosely inside the cavity. The exacting cause is usually a minor trauma or straining at defecation, but spontaneous torsion sometimes occur. Pathology. The testis rotate from outside inwards. It becomes edematous and congested. The color becomes dark, and finally gangrene occur within the 8 to 12 hours if the condition is not treated. The spermatic cord shows the twist, one or more. If torsion persists, the blood vessels are thrombosed. There are hydrohematocele in the tunica vaginalis. The scrotal skin is red and edematous. Clinical picture. The patient presented by sudden, severe, agonizing pain in the scrotum, groin, and the lower abdomen. It may be associated with vomiting, but it is not persistent. Sign. The scrotum is swollen, acutely tender swelling. The overlying skin is edematous and red. The testis is higher than normal. Shock and with tachycardia and sweating may be present in rare case. Differential diagnosis. It could be acute epididymoorchitis associated with the or simulating the acute epidemic orchitis. The torsion of the testis should be differentiated from the acute epididymoorchitis. And torsion of undescended testis had differentiated from strangulated inguinal hernia. Investigation. Patient should undergo the urgent Doppler to detect obstruction of the flow in the vessels, then urgent duplex scan, if available, adds more confirmation by detecting the thrombus in the vessels as well. exploration, the third method of investigation, if previously mentioned investigation are not available and the diagnosis is suspect. Exploration is indicated even if it prove negative, and any delay may lead to loss of the testis. Treatment of the torsion of the testis: urgent surgery, scrotal incision, torsion is undone. If the testis is valuable, the tunica vaginalis is everted and the testis is encouraged to the bottom of the scrotum to prevent the recurrence. يعني نثبتها في bottom of the scrotum to not to again recur of the torsion. If the testis is gangrene, a high orchidectomy above the level of test is done. The opposite testis should be fixed at the same time as the predisposing anomaly is commonly bilateral. This is the timetable for show the differences between the torsion and acute epididymoorchitis. Torsion of the testis, age usually adolescents and children, whereas the acute epididymoorchitis usually adults or elderly. History: in torsion, sometimes mild trauma. In acute epididymoorchitis, usually UTI symptoms are found. Temperature: normal or slightly elevated in torsion, whereas in the acute epididymoorchitis, elevated the temperature. Elevation of the scrotum does not elevate the pain in torsion of the testis, whereas in the acute epididymoorchitis show partial pain relief. Urgent urine analysis in torsion is free, whereas in acute epididymoorchitis may show pus cells. Urgent Doppler or duplex in epididymoorchitis, patent testicular vessels, whereas in the torsion of the testis, obstructed testicular vessels by thrombus. Inflammatory condition of the testis and spermatic cord, which call it, if inflammation occur in the testis alone, call it orchitis, and which is very rare. And it is usually associated with the inflammation of the epididymis, we call it epididymoorchitis, or with the spermatic cord and epididymis, we call funiculoepididymoorchitis. It may be acute or chronic. Acute non-specific epididymoorchitis, this is fairly common disease. Mode infection is usually ascending infection from the UTI or from the urethritis, can lead to the epididymoorchitis, or from the blood-borne infection, secondary to do specific fever or mumps. Usually we say these cases in mumps infection, then patient complain of secondary epididymoorchitis. Clinical picture: there may be history of prostatitis or mumps, acute severe scrotal and groin pain, constitution symptoms like malaise, fever, rigors may be present. The epididymis and the testes are swollen, tender, with redness and edema of the skin. A small secondary hydrocele may be present. Inflammatory may be subside spontaneously, but recurrence is common. Commonly, pus cells are detected in urine analysis. Treatment: we start with the antibiotic, usually a member of the quinolone group, is given for 2 to 3 weeks. A residual epididymal mass may be persist for up to 6 weeks and then resolve spontaneously. Rest of the first few days. Chronic specific epididymoorchitis, which is common, is the tuberculosis. The epididymis is the primary site of affection in genital tuberculosis. The disease occurs mainly in the young male. Infection usually reach the epididymis through the vas deferens from the tuberculosis of the seminal vesicles and prostate. Multiple tubercles affect the tail of the epididymis. The nodules enlarge and may undergo caseation and cold abscess formation. It becomes adherent to the skin and bursts to form a tuberculous sinus or posterior aspect on the posterior aspect of the scrotal skin. The vas deferens is thickened and studded with the multiple tubercle beading or seeding. The testes usually remain free for a long time, but in the neglected case, it may be affected. Treatment is usually by using of the anti tuberculosis drug. If there is no response to conservative treatment after 2 months, excision of the vas deferens and epididymis is indicated. Thank you for listening, and we hope to explain the main important topics in the genitourinary system. Thank you.